Assalamu alaikum. Let's dive into chronic cough, one of the most high-yield topic of the respiratory system. Okay, start with the etiology. Common etiology of the chronic cough. When you find a patient with chronic cough, think about, is it upper airway disorder, or is it lower airway, or lower airway and parenchymal disorder, or maybe the other cause like drug issue or other cause. So upper airway disorder may be upper airway cough syndrome and chronic sinusitis. So upper airway is upper airway cough syndrome or postnasal drip, and chronic sinusitis. Lower airway and parenchymal disorders are asthma, which is obstructive lung disease, post-respiratory tract infection. There may be chronic bronchitis. It is also obstructive lung disease, bronchiectasis, lung cancer, and non-asthmatic bronchitis, non-asthmatic eosinophilic bronchitis. These are the lower airway and parenchymal disorder. Other cause like GERD, gastroesophageal reflux disease, and drug, maybe due to the drug AC inhibitors. AC inhibitors, you can remember like angioedema. AC inhibitors can cause angioedema. AC inhibitors can cause cough, and E for electrolyte imbalance. AC inhibitor can cause electrolyte imbalance. It can cause hyperkalemia. Okay. Approach to chronic cough in children. Very, very, very high yield. Chronic cough means cough more than 4 weeks. Cough more than 4 weeks, and focal examination finding or specific cough feature may guide alternate approach such as paroxysmal, suppressible, and choking or sudden onset foreign body, and red flag like TB and immunodeficiency. So think about these two. Like, is it paroxysmal cough? It may be pertussis. Is it suppressible? Maybe habitual. Is it choking or sudden onset? Maybe foreign body. And red flags like TB and immunodeficiency. If there is chronic cough more than 4 weeks, do spirometry. Evaluate for evaluation evidence of reversible airway obstruction. Evidence of reversible airway obstruction. If it is reversible, the airway obstruction looks like asthma, but then if it is reversible airway obstruction, yes, improvement with trial of SABA and ICS, yes, treat for asthma. If no, if it is not improved by SABA, ICS, no, do a chest x-ray. If chest x-ray is normal, wait and watch. If chest x-ray is abnormal, treat the underlying diagnosis. If there is no evidence of reversible airway obstruction. If there is no evidence of reversible airway obstruction, do a chest x-ray. So this is a simple pathway where you can find easily, where you can reach the diagnosis easily. So chronic cough more than 4 weeks, do a spirometry. If a spirometry shows evidence of reversible area obstruction, yes. Improvement with trial of SABA and ICS, yes. Treat for asthma. If it is no, do a chest x-ray. If chest x-ray is abnormal, treat underlying diagnosis. If chest x-ray is normal, wait and watch. If there is evidence of reversible airway obstruction, no evidence of reversible airway obstruction, do a chest x-ray. Okay, We'll look at here. Evolution of subacute, that means 3 to 8 weeks, or chronic more than 8 weeks of cough. Suspected etiology on history and physical examination. Suspected etiology on history and physical examination. Evaluate and treat as indicated. Evaluate and treat as indicated. If it is it AC inhibitors? If it is due to AC inhibitors, stop the AC. If it is due to upper airway cuff syndrome, if there is upper airway cuff syndrome, give first generation H1 blocker like chlorpheniramine. If it is asthma, do pulmonary function test and treat accordingly. If it is GRD, empiric PI can be given. No improvement after intervention. No improvement after intervention. Do a chest X-ray. If suspected etiology on history and physical examination H and P looks like parenchymal disease, purulent sputum, or immunocompromised, no specific etiology, do a chest X-ray. What is the next step in management? What is the next step in management for a young patient who presents with chronic nocturnal dry cough with a sensation of liquid dripping into the back of the throat? So chronic nocturnal dry cough and liquid dripping in the back of the throat. Oral first generation H1 blocker should be given. This patient has upper airway cough syndrome postnasal drip and should be treated empirically and should be treated empirically. Okay. Another important topic is hyperventilation syndrome. It's a diagnosis of exclusion actually, and by intermittent episodes of hyperventilation without any obvious cardiac or pulmonary etiology. Neurologic symptoms include paresthesia, headache, lightheadedness, carpopedal spasm, can often related to cerebral vasoconstriction or alkalosis-induced hypocalcemia and hypophosphatemia. If the episode does not improve with breathing retraining, a small dose, not a high dose, a short acting benzodiazepine, lorazepam is appropriate second line therapy. Breathing into a paper bag was previously recommended to improve hypocarbia by rebreathing carbon dioxide. However, this can also result in hypoxia and therefore should not be done. Okay, now look at this question. This 32-year-old woman um, complains of nagging dry cough over 8 weeks. So it is chronic cough. Cough is present during the day and awakens uh, her at night. There is no associated shortness of breath, chest pain, wheezing. The patient's medical history is chronic rhinorrhea, very high yield, and an occasional itching, skin rash. She takes no medication. Chest X-ray show no abnormality. 1 week of treatment of chlorpheniramine improves her syndrome. Decreasing which of the following is most responsible for her symptoms relief? So decrease in which of the following is most likely symptom release, that is nasal secretion, and it is look like upper airway cough syndrome. The most common cause of etiology of chronic cough more than 8 weeks, upper airway cough syndrome, postnasal drip, asthma, and GRD. Upper airway cough syndrome is caused by rhinosinus conditions including allergic, peri neal, non-allergic, and vasomotor rhinitis, acute nasopharyngitis, and sinusitis. Cough is caused by mechanical stimulation of the afferent limb of the cough reflex in the upper airway. In this condition, based on the history, this patient's dry cough is most likely due to PND, postnasal drip, associated with allergic rhinitis. The diagnosis is confirmed by improvement of the nasal gestures and cough with the use of first generation antihistamine. Chlorpheniramine is a specific H1 antihistamine receptor blocker that reduces the action of histamine on H1 receptor, decreasing the allergic response. In addition to blocking H1 histamine receptor, chlorpheniramine exhibits anti-inflammatory effect by blocking histamine release from muscle and limiting the secretory response of the inflammatory cytokines. Okay, now next question. Look at this on this 50-year-old man comes to the office after 4 weeks of non-productive cough. The cough is constant throughout the day and very annoying. The patient was diagnosed with non-ischemic cardiomyopathy 2 months ago when she was hospitalized with shortness of breath and lower extremity edema. She reports marked improvement with breathing and no nighttime awakening. The patient has no fever, sore throat, rhinorrhea, chest pain. Medication include carvedilol, lisinopril, spironolactone, and torsemide. The patient smokes cigarettes from age 25 to 30. He does not use tobacco, alcohol, or illicit drugs. Okay. Oropharynx is clear, JVD is flat. She's supine, lungs are clear, no peripheral edema, a faint systolic murmur present on the apex, chest ratio mild cardiomegaly, and clear lungs. So, in this whole stem, there is no signs of asthma, there is no signs of GRD, and this patient has 4 week no signs of rhinosinusitis. Looks like the drug spironolactone, sorry, looks like the drugs lisinopril is causing these dry cough. So we know that AC inhibitor can cause dry cough. So that is the answer. Okay, look at this question. This 35-year-old man comes to the physician with a 3 week history of non-productive hacking, non-productive cough that occurs more frequently at night. He also has sensation of liquid dripping into the back of the throat. He has no upper respiratory infection 4 weeks ago. Expect except for the cough, he has no runny nose, chest pain, heartburn, difficulty breathing. The patient has a medical history is unremarkable. His lifetime, he's a lifetime non-smoker. His father died of lung cancer. Which of the following is the best initial management for this patient? So this point is very high, like liquid dripping back into the throat and had an upper respiratory tract infection 4 weeks ago. Looks like upper airway cough syndrome. An oral first generation antihistamine should be given. So this patient's cough started after recent upper respiratory infection, commonly at night, is without expectoration cough following upper respiratory infection, cough following upper respiratory infection, which can be upper airway cough syndrome or the effects of the virus. The best approach is to treat empirically with oral first generation antihistamine, chlorpheniramine, or antihistamine decongestant, combined antihistamine decongestant, brompheniramine, and pseudoephedrine. Despite their sedating effect, first generation antihistamine are used because they are more effective. The approach differs from that used for symptoms thought to be rhinitis is if there is rhinitis in which intranasal glucocorticoid are the first line Patients who do not respond to 2 to 3 weeks may require further investigation like sinus imaging, pulmonary function test, high-resolution CT scan, or empiric sequential therapy for GERD, cough variant asthma, chronic sinusitis, and non-asthmatic eosinophilic bronchitis. Okay, that's all about my chronic cough lecture. Hope you enjoyed.